Hi guys, welcome back to the channel. So we'll be starting the third, that is peripheral giant cell proliferation. Let's start. Peripheral giant cell proliferation, clinical presentation and pathogenesis. Soft, fleshy, broad-based and easily bleeding mass. It will arise from the gingiva, but it may also arise from edentulous ridge. So we have seen that peripheral ossifying fibroma doesn't occur in edentulous area, but peripheral giant cell proliferation occurs from an edentulous ridge. Are associated with failing dental restoration, sharp toothed edges or foreign bodies. Some will attain sizes of 5 to 7 cm and may develop superficial ulcerations with a fibrin base, mimicking a fungating tumor. There is a slight female predilection. An enigmatic lesion that seems to arise from the periosteum or PDL and contains granulation tissue with osteoclast. Now, coming to differential diagnosis, pyogenic granuloma, peripheral ossifying fibroma, primary or metastatic malignancy. Okay. Now coming to radiographic finding. Seen best in edentulous area will characteristically show a cupped out resorption of the alveolar crest and sometimes of the root surfaces. So it shows cupped out resorption of the alveolar bone radiographically. Histopathology, a discrete tumor mass is usually seen. Covering mucosa may sometimes be ulcerated. Numerous capillaries and an inflammatory infiltrate with prominent plasma cells. It is cellular and consists of spindle cells, multinucleated giant cells and some extravasated blood. Hemosiderin at the periphery may be present. Okay, so a discrete tumor is seen. A covering mucosa may be ulcerated. Capillaries and inflammatory infiltrate mainly plasma cells and cellular उसमें spindle cell multinucleated giant cell दिखेंगे और हेमोसिड्रिन दिखेगा because extravasated blood is seen. Now coming to treatment, excise with 2 to 5 mm surgical margin at periphery and the excision should include the periosteum and or PDL from which they thought to arise. तो पेरियोस्टियम या पीडियल जो भी है वो उसको इंक्लूड करना है एक्सीजन में. 2 to 5 mm of surgical margin at the periphery and the excision should include the periosteum and or PDL from which they thought to arise. Okay. Now, apparent stimulating etiology such as failing restoration or foreign body should be removed with the lesion. Obviously नहीं तो फिर recurrence ज़्यादा होगा. तो जो PDL या पेरियोस्टियम साथ में लेना है और अगर जो भी etiology है पीछे जो भी stimulating etiology है जैसे failing restoration हो गया, foreign body हो गया, ये सब भी it should be also excised with the lesion. The resultant defect is left to be healed by secondary intention if primary approximation of tissue is not possible. अगर हम ऐसा लीशन निकालें और वो डिफेक्ट बन गया और हमारा प्राइमरी अप्रॉक्सीमेशन नहीं पॉसिबल है तो इट शुड लेफ्ट टू हील विथ सेकेंडरी इंटेंशन. इट विल हील बाय सेकेंडरी इंटेंशन. So the resultant defect is left to heal by secondary intention if primary approximation is not possible. अगर primary approximation हो रहा है तो कोई बात नहीं, लेकिन अगर defect ऐसा बना है कि primary approximation नहीं हो पा रहा है then it will heal by secondary intention. Now prognosis. Excision of the lesion and removal of any stimulators resolve the lesion without recurrence. अगर लीजन अच्छे से एक्साइज हुए हैं और जो स्टिमुलेटर्स है, जो भी स्टिमुलेटिंग फैक्टर्स है, जो भी स्टिमुलेटिंग एटियोलॉजी है वो रिजॉल्व हो गए हैं, वो रिमूव्ड हो गए हैं, तो लीजन का रिकरेंस नहीं होगा. ओके, दैट्स ऑल अबाउट द 3 triad of the gingival masses: pyogenic granuloma, peripheral ossifying fibroma and peripheral giant cell proliferation. Hope all these terminology are clear. We'll be starting with the next topic, in next class. Till then, like, share, subscribe and comment. Bye.